Welcome to the second annual Yale Institute of Global Health Symposium. For those who don't know me, I'm Megan Ranney. I'm the Dean of the Yale School of Public Health, and I'm absolutely delighted by the work that YIGH has done over the past year. We're here during a truly unsettled and unprecedented time, both for public health and for global health. And at this moment, as those of you who are in my school know, my motto is that the only way through this is to literally go through it, but to do so together. And that's where bringing us together as a community at Yale committed to global health in this moment is more important than ever. If we are to continue with our mission of advancing the health of humans across the globe, we must share our latest innovations, our barriers, our connections, and most of all, our mission and methodologies with each other. I'll say that this moment to me also underscores the importance of the Yale Institute for Global Health and all of the efforts that are led by our faculty, staff, and students across the globe. I want to thank in particular our own Dr. Capello for his leadership in guiding YIGH, including the search for a next director. I think he gets huge kudos for serving 2 years as interim director, and not serving as interim director in a way that just lets the status quo continue, but it has really elevated the footprint of this institute across campus. In terms of the new director, for those who are interested, along with Dean Brown and Dean Amami, we're continuing with the search and we'll hopefully have some announcements soon. I'll say on behalf of all three of us, we remain unbelievably committed to the Institute as well as, of course, to the work of global health at Yale. Today you have an action-packed morning, starting with Dr. Tedros, who will be joining us remotely. He is affiliated with the school, actually got started in public health by working with our own Betsy Bradley when he was Minister of Health in Ethiopia. And there's no one better than him to talk about how we navigate current challenges, particularly with the US pulling out of the World Health Organization, and the ways in which academia can play an ever more important role in maintaining those connections and collaborations and data sharing. I'm also tremendously pleased to welcome our colleagues and my friends from the Association of Schools and Programs of Public Health. We have Dr. Laura Magana, the President and CEO, and Tim Leshen, the ASPPH Chief External Relations and Advocacy Officer. Just a few weeks ago, I spent days in Washington, D.C. for our ASPPH annual meeting, but also for Capitol Hill Day. And I was able to both witness firsthand the power of advocacy and action, but also participate in our great democracy. I know that many of you, our students, went down to DC as well with Mike Skinitsny and Rafael Perez Escamilla about a month ago, doing similar work, and I'm tremendously grateful for that. Again, as we think about the future of global health, how we continue our mission, how we continue our work, part of that is making sure that the impact of our work is known to those in power, as well as to those who are in the grassroots on the ground with whom we're working. Finally, I'm just grateful to see all of you today, both those of you here in person and those who are on Zoom. Rob Hecht, I'm glad you made it back from China safely. We're glad that you're there and can hear us. We have a really outstanding list of speakers and look forward to hearing about the trailblazing efforts in global health that not only our faculty, but again, our students and staff are engaging in. So, with that, thank you all for being here. Thank you for the work that you do. Thank you for persevering in the face of challenge and uncertainty, because that's what we do. And I will say as an ER doctor, when we give up, that's when you actually say that we've reached the end. There is no time right now to give up. Our work matters more than ever, and you being here, you're continuing what you do, you're finding new sources of funding, you're persisting in maintaining those community partnerships that you've worked so hard to build. That matters more today than ever, and I'm hopeful that this day is going to provide you a little bit of a lift beneath your wings as you go forth and continue the work. So thank you, and with that, I'm going to turn it to Michael Capello, again, who is Interim Director of YIGH and the Chair of our Epi of Microbial Disease Department here at YSPH, to officially open the symposium. Thank you, Michael.
So thanks, Dean Ranney, and welcome everyone. Please come have a seat. As Dean Raney mentioned, I'm the interim director. I'm Michael Capella, the interim director of the Institute and chair of the EMD department here. I'm also an infectious disease clinician in the Department of Pediatrics in the School of Medicine. I just would like to say a few words about today and its origins. So much like last year when we launched the annual symposium with our inaugural event in this room, in putting together this year's symposium, we really had two fundamental objectives. First, we wanted to, given the circumstances and the current situation, we wanted to create some space for people to come together and talk about some of the both challenges and opportunities that are facing the global health community here at Yale, in the United States, but also around the world. And with that in mind, we sort of intentionally set up our program so that we would have opportunities, for example, through Dr. Tedros' remarks, which will come soon, through our special guests from the ASPPH, and also from some of the panel discussions and conversations that we'll have. So it's very important, I think, that we use this opportunity today to find or to enrich our sense of community and learn about what's happening in our neighborhood and also around the world. And the second objective of today's event is, I'll be honest, is really the thing that I am most inspired by and interested in, and that is a chance to just hear about all of the amazing work in global health that's being done here on campus, whether it's research, educational programs, clinical care, capacity building. We have such a rich portfolio of global health activities, and one of the really best things about being interim director has been to learn about what's happening across the entire university and even beyond the health sciences. So before we start today, I would like to take a moment to thank the Yale Conference and Events Office who helped put this together, and a special thank you to the YGH staff. If we could have our staff just kind of raise your hand or stand up, I really think that you guys... So this is a wonderful group of faculty, staff, and students who really support the activities of the Institute, who give of their time and energy and wisdom to be part of this effort. And quite simply, the Institute really could not survive, much less thrive, without their contribution. So I'm very grateful for that. So next up, today's morning session, we will have video remarks by Dr. Tedros, followed by a panel discussion with some of our faculty talking and reflecting about some of the issues that Dr. Tedros remarks on, but also speaking more broadly about the state of global health, if you will. You know, I was planning to give an introduction, but first I'd just like to see a show of hands. Does anybody not know who Dr. Tedros is? Yeah, I didn't think so. So I can avoid or sort of dispel with the introduction, but I do want to at least mention that he is the first WHO Director General from the Africa region. I think that's very important, and I think it's also important to understand his background. In addition to having been the Ministry of Health in Ethiopia, he also served in a number of other important positions. And I want to highlight that, I think, for some of our junior people and trainees and students in the room, that really it's about acquiring the experience that positions you for one of these roles like Dr. Tedros plays today. So it's really important, I think, to seek opportunities to gain experience and to build out your own personal portfolio. For example, he was chair of the Global Fund to fight AIDS, TB, and malaria. He was chair of the board of the Rollback Malaria Program, and he was co-chair of the Partnership for Maternal, Newborn, and Child Health Board. So he really does have a diverse set of experiences prior to becoming Director General, and I thought it was important to highlight that. So without further ado, I will click a button up here, and we will begin listening to Dr. Tedros, and as I said, afterwards we will have a panel discussion. So let's see if it works. There we go.
Dean Megan Rennie, Dean Nancy Brown, Dean Azita Imami, Dr. Michael Capello, members of the Yale community, dear colleagues and friends. I'm sorry I cannot join you virtually today, as I had planned. As you meet, WHO member states are in Geneva in the final stages of negotiating the WHO pandemic agreement, and I need to be in those discussions. After 3.5 years of negotiations, countries have committed to concluding the agreement for adoption at next month's World Health Assembly. If they succeed, and I'm confident they will, the pandemic agreement will be a landmark instrument of international law that addresses the gaps in global health security exposed by the COVID-19 pandemic: insufficient cooperation between countries, inadequate sharing of information, and inequitable access to vaccines and other medical countermeasures. The agreement is based on the fundamental principle that shared threats demand a shared response. The COVID-19 pandemic may now seem like a distant memory, overtaken by conflict and geopolitical and economic turmoil. In the same way, the 1918 influenza pandemic was overshadowed by the First World War, even though it killed more people than the war and its lessons went unlearned. We cannot make the same mistake, because as students of global health, you know that the next pandemic is not a matter of if, but when. It could happen in 20 years or more, or it could happen tomorrow. Either way, we must be ready. As some of you may know, I have a long history with Yale, going back 2 decades when I served as Minister of Health, Ethiopia. As a low-income country, Ethiopia was receiving a lot of foreign aid, but most of it was targeted at specific diseases such as HIV, TB, and malaria. Our priority, though, was to strengthen the foundations of our health system. Working with Yale and the Clinton Health Access Initiative, we developed and launched an ambitious reform plan that led to significant improvements in hospital management, service quality, and ultimately to better health outcomes. We worked closely on the management reforms with Professor Betsy Bradley, then of the Yale School of Public Health, my good friend, and Professor John Gaddis, who studied the impact of the reforms we made. And, grand strategy helped in preparing our strategic plan. Many of the lessons we learned from that experience remain relevant today because we focused on capacity building of the health system in the country. As you know, the sudden and unplanned cuts to global health by the United States and reductions in development assistance by other countries are impacting the health of millions of people around the world, especially the most vulnerable populations. The U.S. has been extremely generous over many years, and of course, is within its rights to decide what it supports and to what extent it can use its money. Unfortunately, the sudden withdrawal of funding without notice or warning has caused severe disruption to health services, information systems, and supply chains, closures of health facilities, job losses for health workers, and increased out-of-pocket health spending. We hope the U.S. administration will reconsider its support for global health, or at least continue funding for a limited period to give countries time to adjust and plan. But countries must also see this as an opportunity, forced by necessity, to finally transition away from aid dependency to sustainable self-reliance based on domestic resources. WHO has long supported countries to move in that direction, and we are now helping them to accelerate the transition. Already, several countries have taken significant steps. For example, South Africa's parliament has approved an additional $1.5 billion for its health budget this year. Nigeria has allocated an additional $200 million to health in its 2025 budget. Kenya's Health Ministry has requested an additional $250 million from the National Treasury to support health services. And Ghana is also taking steps to bridge its financing gap. The Yale Institute of Global Health could play an important part in this process by helping countries to make the transition and supporting them to manage the disruptions they face. As you know, the US has also announced its intention to withdraw from WHO, and we're working fast to adapt to that withdrawal. Although this decision came as a shock, we saw it coming. After I became Director General in 2017, we began a process of transformation, identifying weaknesses and taking steps to address them. We identified WHO's over-reliance on a handful of traditional donors, especially some of the traditional donors at the single greatest risk to the organization. Since then, we have taken several steps to address that risk and broaden our donor base and put us on a more sustainable and secure financial footing. We are now accelerating that work. Although we face a very challenging situation, we see this as an opportunity to reshape the organization to make it sharper, stronger, more empowered, and more independent. One of the ways we want to do that is through our network of collaborating centers around the world. When WHO was founded in 1948, WHO's member states decided that WHO should not establish its own research institutions, but use the expertise and capacity of institutions all over the world. Today, we have more than 800 collaborating centers in more than 80 countries, including the Yale New Haven Center for Emergency Preparedness and Disaster Response. We would also like to explore with you possibility of establishing a collaborating center at the Yale Institute of Global Health. Additionally, we're also in discussions with the Institute about a new idea called the WHO Youth Fellowship Towards Equity, which we have developed with the WHO Youth Council. The idea is for the Institute to sponsor a certain number of fellows from Yale and an equal number from an institution in a low or middle-income country. The fellows would work together at WHO on a collaborative project overseen and mentored by WHO staff. The idea could be a pilot that, if successful, could be rolled out to other universities, giving valuable experience to students from both high and low-income countries and contributing new ideas and perspectives to WHO's work. Dear colleagues and friends, Monday this week, the 7th of April, was World Health Day, WHO's 77th birthday. The vision our founders had in 1948 remains our driving force today. The highest attainable standard of health, not as a luxury for some, but a right for all. That's the right for which I and the dedicated, committed people I'm honored to call my colleagues will continue to work every day. I thank you.
Good morning. So my name is Jeremy Schwartz. I'm at YGH, the director of the Faculty Network Program, and you weren't slated to hear from me for a little while until a little while later. But we have a faculty panel that came together in the last 12 hours when we learned that Dr. Tedros would be unable to be here live. And so I'd like to welcome up my dear friends and colleagues who I'll introduce. So please, guys, come on up. So thank you all for being here. So at the end, opposite me, is Dr. Luke Davis, an associate professor of epidemiology of microbial diseases and medicine in the pulmonary critical care and sleep medicine department. Next, Tracy Rabin, who for full transparency is also my wife. an associate professor of medicine and general medicine, and a clinical professor of nursing at the School of Nursing. And Nikki Hawley, an associate professor of epidemiology and chronic diseases and anthropology. I'm really excited, thrilled to be able to have this conversation with you all. At the same time, it's a little bit terrifying because we're doing this last minute and we're responding to Dr. Tedros' remarks. So thanks for being here. So I thought we could start with just some personal reflection. I'll say for me, the U.S. withdrawal and disengagement from WHO just is like it feels like a real hit to the heart. And I was just walking over here, reminding myself that the withdrawal came on the very first day of President Trump's new term, right? So it was amongst the most important things that had to be done immediately. And so I thought maybe we could just open with some comments, personal reflections on what this means to you, what WHO means to you or has meant to you during your career, and implications personally in your own work around the withdrawal. So maybe Luke, do you want to start?
Yeah, thank you, Jeremy. It's great to be with everyone today. I really enjoyed hearing Dr. Tedros' remarks and having the chance to know more about his connections with the way at Yale. I came to Yale about 10 years ago. And when I think about WHO, one of my formative experiences was very helpful when I was in my postdoctoral fellowship. I had the opportunity to participate in a WHO expert review. So those who aren't familiar, WHO maybe 15 years ago really changed the way that it developed its guidelines and moved away from an approach where it was expert opinion to really trying to ground its recommendations in evidence, and developed a very rigorous process for doing that. And part of that process involves systematic reviews that are often put together by young trainees. They have a chance to work with senior mentors who are experts in the field, in my case, in the field of tuberculosis, and also with methodologists. And I had a chance to visit WHO for 3 days and participate in those meetings and see how policy is made. And it really helped me understand that while WHO is a relatively small organization, I think it's around 10,000 people, 2,000 or 3,000 people in Geneva, and the rest kind of scattered around the world, it plays a really important role in making sure that what we're doing in global health is evidence-based. And that really meant a lot to me to see how that process worked. And I think it's been a guiding force. Even today, whenever I write a grant, I always start by talking about what are WHO's priorities for tuberculosis, what are WHO's priorities for low and middle income countries where the greatest burden of disease is, and thinking about how it represents those opinions both in evidence and also in the needs of the community. So it was really nice to hear from Dr. Tedros today, thinking about what the future might look like, where there is a greater voice for countries themselves kind of taking a role in leading health. But that doesn't take away the opportunity, hopefully, for us and many in this room who don't come from low and middle income countries, who want to have the opportunity to have an impact, to use the training that you have an opportunity to get at a place like Yale to identify innovations and help advance them.
Thanks, Luke. Tracy?
Thanks, Jeremy, and thanks, Luke, for those remarks. I also really enjoyed listening to Dr. Tedros' remarks. I think some of the things that particularly struck me had to do with this focus on capacity building and the importance of that as we move forward. And then also these ideas about developing a collaborating center, and additionally the youth fellowship idea. And I would say that struck me in part because before I became a physician, I was actually working in public health for a number of years. I went to public health school. And one of the sort of seminal experiences of that time was actually an internship at WHO. I spent a summer working for TDR, the program on tropical diseases. And then had the opportunity after graduation to go back as a consultant. And my time there was focused on supporting training around basic sort of epidemiology skills. They were developing a package that was being rolled out in other countries and supporting that team. But while I was there, I had the opportunity to sort of sit in on different meetings and get to have a sense of just the breadth of issues that WHO is concerned with, and just to be so impressed by the commitment of the people that work there in Geneva. And then since then have had the opportunity to interact interact with folks in sort of country offices, specifically in WHO office in Uganda, and just really see sort of how things are translated to the country level. And so I think, even from those early times, just this idea that there was this tremendous network of committed people who were really focusing on the engine of what drives public health and sort of making sure that the structures are in place was just something that was very meaningful to me. And then sort of going on to become a physician where I'm focusing, I'm trying to balance focusing on individual patients versus thinking about populations. But even still, when I teach a lot about diabetes. I always start my lectures with, here's what the burden of diabetes is in the world, and here's what's happening in the world. And I think that that's an important perspective for our clinicians in training here to hear as well.
Great. Thanks, Tracy.
Thank you so much. Thank you for the opportunity to be here. And I'm going to pick up a little bit on that thread about teaching. So not only did President Trump come into power at the beginning of this year, but I began teaching my course in global non-communicable diseases, which I teach here every year, have done for 7 years. And the foundation of that course is evidence that is mostly generated by the World Health Organization. And so in real time, my students and I think, have been grappling with this very emotional response to what does it mean for the US to withdraw their support for the World Health Organization? What does this mean for global health? What does this potentially mean for the loss of human life? And it was important to kind of process that, but then to sit back for a second partway through the semester and say, but wait, actually, there have been very talented scholars writing for decades now about the vulnerabilities of WHO, as Dr. Tedros said, in terms of over-reliance on donors, about the need to maybe shift reliance on these multilateral organizations to more country-led solutions. And so we've been able to think a little bit about actually maybe this is a moment to accelerate some of the progress towards universal health coverage and countries thinking about developing their own systems of financing that I think many of us in the field have been calling for so long. And I really appreciated actually Dean Rani's comments at the beginning of this about this is a real moment that we have to go through. But I also think that these moments of pressure and stress are when we see innovation, and this is probably going to catalyze a global health environment that looks very different and one that we should be excited about contributing to. So I'm holding on to the optimism in Dr. Tedros's comments.
Yeah, that's fantastic. Thank you. I think there's a lot to reflect on in terms of opportunity and flipping the script here. So maybe before we go to specifically reflecting on Dr. Tedros's comments about opportunity, another thing I was reflecting on while walking in this morning was this widely used definition of global health that was put forward in 2009 by Dr. Jeff Copeland and colleagues. And I'm just going to read it and remind us what's there. And the question, to preface my reading this, is going to be around what's missing from this definition? Is this an opportunity to start rethinking how we all think about global health? And so let me just read that. So we offer the following definition. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level care. And we certainly have used this definition in YGH to sort of define how we think about global health. But are there elements that are missing? Are there elements that are under stressed? And what are the opportunities there? Nikki, do you want to start off? Or I don't need to call on you. We're among friends. So.
That's an enormous question. I'm actually a big believer in that definition, and maybe others will say that there are pieces missing. I think the definition is right. What I don't think we've done is walked the walk over time. And so I don't think that the way that we have practiced global health traditionally has prioritized multiple stakeholder input or really true kind of international collaboration. And so for me, the Pandemic Accord, for example, is an amazing opportunity to actually like embody those principles of global health. So I think it's not as much that there's something missing, but just that we haven't, and I say collectively, we have not done a good enough job kind of living up to that definition.
I would echo that, Nikki. I actually feel very strongly about that definition as well. But I think those who have been in classes or have heard from me before will know that I often will start off by saying, you know, it turns out that the United States is on the globe. You know, and that usually elicits some chuckles. But I think that a lot of people, when they even hearing that definition, don't necessarily see that there is plenty of global health that is happening here in the U.S. and needs here in this country. And so to me, you know, when I heard about, the administration pulling us out of WHO, I just was thinking to myself, you know, this just reflects such a poor understanding, really, of how interconnected we are and how much the U.S. benefits from membership in WHO as well as our partners around the world. So.
Yeah, I think it's a great definition, and it overlaps in many ways with the definition for implementation science that I am very passionate about. Implementation science is a field, as I kind of alluded to earlier, where we're taking evidence. What do we know works and figuring out how to put it into practice. And I think that probably the biggest thing that I have learned over the years from doing that is that we don't have all the answers. Really, the community often has those answers. And a lot of the ways that we approach public health, one way that I think we could really change is kind of moving a little bit away from the supply side approach. We have a great idea, and we want to make it available to people to really figure out what people want. And in that regard, I think we need to hold ourselves to a higher standard. You know, often in the field of implementation science, we like to ask people, oh, is this feasible? Is it acceptable to you? Is this appropriate for us to bring this new technology? Rather than to say, do you like this? Do you enjoy it? Really, does it give you passion? And I think the only way to do that is to build these strong partnerships with the community to kind of do that. I think another aspect that I've sort of realized often, I do a lot of community-based work in Uganda related to finding people who have TB who aren't aware of it and helping getting them linked to care. And some of these types of approaches that I mentioned, I've learned about through that work. But I've also kind of realized and thought for myself, apropos of your comments, Tracy, that, you know, how would I feel if someone came and knocked on my door and asked me did I have any cough and would I like to get evaluated for TB? And so I think there's a lot that we can learn by putting ourselves in the shoes of the people that we're trying to serve and thinking about what some of these innovations would look like if we brought them here. And I know we'll probably have a chance to talk about more of that later.
Great, thank you. So I think it's a good opportunity to pivot back to some of the things that Dr. Tedros was talking about. One that caught my attention, Tracy, you mentioned a few minutes ago, was this, the Youth Fellowship Program, and specifically around twinning. So as we think about how do we as professors, associate professors of medicine, public health, sitting at Yale, engaging with communities, but are we doing it right? Are we doing it to the best of our abilities? And one way that I find attractive is through twinning opportunities, which essentially means, you know, we, let's say at Yale, have a funding opportunity and we make use of additional financing to support a local student or trainee as a twin, to go through that process of learning and knowledge generation together. And that twin often, always, has very different perspectives that they bring to the table. And there are pros and cons to twinning. I don't know enough about this proposed program. I think he was talking about university twinning, so maybe at a higher level, but maybe an opportunity for us to just talk about twinning either at individual levels or institutional levels and how that helps build partnerships, which I think underlies all of our work. So any reflections on that concept?
Yeah, maybe I'll start, and then it'd be very interesting to hear the other stories that people have. Jeremy, I think we've talked a lot about this. Both of us work in Uganda, and one of the things that I think Yale has done really well is framing the engagement in global health as sort of bilateral and creating opportunities for trainees internationally to come here. I know Tracy can say a little bit more about that, but it's amazing that when you do that, how the trainees come back and say how much they learned from those partners about how different things were than they actually expected things to be. I think what really can often work well is to try to make sure that these projects lead to measurable opportunities for each individual to kind of contribute to a presentation, to a scientific presentation, but also to figure out what the needs are locally in terms of trainees having an opportunity to see what in the country makes a difference in terms of health policy or care or practice.
Sure. Thanks so much, Luke. You know well that I spend a lot of time thinking from a global health education point of view about the benefits of bidirectionality, and so not necessarily twinning per se, but thinking about, if we are engaging with another institution elsewhere for the purposes of meeting educational needs of our trainees, then what is it that we are providing for the trainees? What are we providing to our partner institution, right? Why is it that they should even be engaging with us and hosting our learners if we're not going to also be providing some sort of benefit? And I think just in the world of global health education, clinical education, I'd say, is more where I focus. It's been exciting over the last 10, 15 years to see institutions start to move in the direction of understanding that it is not enough to sort of have programs where you're sending your learners to go and work with colleagues elsewhere, that you really do need to focus on bringing their learners here, both to support our partners, but also thinking about all of the learners at our institutions that benefit from having the perspective of our visitors, all of the folks who won't necessarily have the opportunity to travel for an educational experience, but really benefit from these global partnerships when our colleagues come here and share their knowledge and engage in that learning.
Yeah, I mean, this is not a novel concept, I think, to many of us sitting in this room. Like this, I think, is one of the things that Yale has done best and has done best for a really long time, like even starting with the capacity building that Betsy Bradley built in Ethiopia that maybe contributed to Dr. Tedros being where he is right now. Your collaboration with Makerere and the kind of bi-directional learning is such an important model for universities to adopt. I know that YIGH really prioritizes pilot projects where there is an aspect of twinning. We have one, I'm going to tell you a little bit about it in the next session. The Downs Fellowship that is encouraging our students from the professional schools to go and across campus to go and experience these new international opportunities are actively encouraging their applicants to think about twinning with partner students, and it's such a powerful model, but it's something that we are really good at and we probably need to do more of. We can be a real leader in this space.
Yeah, I mean, one thing that's interesting to reflect on just between, like, Nikki, you're in my programs in Uganda and Samoa, when we think about twinning and the level of training opportunities that exist in the local environment. And, we can think about like training programs. We've talked about this. In Samoa, there's a real paucity of training opportunities. In Uganda, there have been many, dozens of, just specifically thinking about NIH-funded training opportunities. So how does that impact opportunities for twinning, sort of the pool of people who are ready to enter into engagements like that? I don't know if you have any reflections.
Yeah, so to share, I've been working for the past year or so, on a D43 application that would provide training to anywhere from university level students, high school students, to early career faculty in Samoa, where there is a real gap in academic capacity. We literally do not have academic partners with whom to collaborate. And so this is really a ground roots effort, and I've been thinking a lot about how we do this. And I approached the Director General of Health and the Minister of Health about this. And somewhere in the conversation, real crosswires, and they said, absolutely not. Are we sending our people to Yale for 2 years to do an MPH program because they will never come back? And I said, no, this is not what we're going to do. And so we had always planned, but in that moment really reiterated our goal to try and bring Yale resources to Samoa to develop their Masters in Public Health program, to contribute our methodological and technical expertise to really allow them to build a train the trainers model that could be sustainable over time. And so I've totally forgotten the origin of this question, but I think it's really important to think about capacity building in a way that takes it to the countries that we partner with. One of the biggest things that I think I take away from this shift away from US engagement is that in the future, we in the room, and particularly our students, in the future are going to be working with countries and not for them. And so I think it's a real, really important thing to be thinking about as we move forward.
Thanks. So another one of Dr. Tedros' comments was about how Yale and YGH could help support countries in this transition from dependency. And that was striking, and it was really, I think it was energizing for me to hear that he has that sense that academic institutions can really help countries transition. Can we talk about that? I haven't formed a great question, but I was struck by the comment. And just to say, we're going to open this up any minute to comments and contributions from you, because the Q&A was supposed to be a major part of Dr. Tedros' talk. So just patience for a minute.
Yeah, I thought it was really interesting that he talked about the collaborating institutes. I don't think I was aware of that. I don't know. Are any of you involved with the? It sounds like we have one at Yale in terms of emergency preparedness.
Yeah, there's one. It's at Yale New Haven Health, and it's based, I think, in Stratford. I was just looking at it this morning,
okay.
But I hadn't heard anything about it. We've within our NCD focused faculty network, we've talked about working towards being a WHO collaborating center. So there are certain requirements about sort of ongoing engagement with WHO, but I think that's the only one that exists right now.
Yeah, we should definitely try to do this. This seems really exciting, and it sounds like, I think he said 800 institutes around the world, so we'll have a lot of models maybe to emulate and figure out what models we might want to adopt.
Yeah. What, I mean, how do you see what we do, what our colleagues do, as being able to support countries in this transition, this moment in time?
I mean, I think it's a great question. I also appreciated hearing that from him. I think one thing that will be important, though, as we consider how to sort of take up this charge, is to keep in mind that expertise comes in many forms, right? And so even though we're at an institution that has a name that's widely known, and there are many people who've spent a lot of time thinking and studying and doing research on various areas, that doesn't mean that we are necessarily experts in the room in a given place. And so I think as countries are trying to sort of think about their own strategies for, this accelerated health independent, I think that it's important for us to show up as partners and to say, these are the things that we can contribute, and to have listening ears when they say, these are the things that we want from you, and to really see ourselves as partners, but also to recognize that, we are not necessarily experts in that room. There are things that we may bring to it that are helpful, but that doesn't necessarily mean that we have the knowledge necessary to move them forward.
Yeah, I think what Betsy and Tedros did together really speaks to that, and to me that's that's one of the reasons she's a hero here, and personally, through that ongoing collaboration that led to real strengthening of their health system and capacity strengthening. Any other comments?
Yeah, I think one of our strengths, again, is the long-term relationships that we, several of us in the room, have with countries that can be a model for a model for engagement, like your work in Uganda and my more than a decade collaboration with Samoa and many other.
And looking
exactly
everywhere.
Looking out at this room, there are incredible trailblazers in terms of developing these long-term partnerships that are going to be so important to learn from as a foundation for this.
Great. Mike, where are you? Is this a good moment to open it up? All right. So I think we have a couple of folks circulating with microphones. Again, this was intended to be a Q&A with Dr. Tedros. We are not Dr. Tedros, but we'd love to talk with you. And so the floor is open for questions, comments, additions. Christina, why don't you start us out? Yeah.
I can project.
Here's a mic. There's a mic. Yeah.
Oh, wow, thanks. That was fast. Okay. Hi, you all. Thanks for doing this. It's always wonderful to hear your perspectives. I was wondering if you've had a chance to talk yet deeply with your own partners about their reflections on these moments and some of the things that Dr. Tedros was saying. And I'll just share, yesterday I had a colleague from Liberia, where I also have a decade-long partnership, join my class. And he is a very senior person in the national public health arena. And he was saying this is a wake-up call for us. And we are actively realigning our priorities. But Dr. Tedros made the point, it's been very abrupt. And so it's interesting to hear our colleagues and partners kind of reflect on. My colleague also talked about this culture of dependency and wanting to move away from that. And so it's an interesting moment, very paradoxical in some key ways. I'm just curious what you're hearing from your partners.
I could tell a little story. So I mentioned that I work in Uganda, and most of our work is focused on TB clinics, but we also have some activities that touch on HIV clinics. And one of our current Global Health Equity Scholars Fellows, Dr. Stella Zawede, is a close colleague and a collaborator. And it's been really interesting to talk with her. She works with one of the implementing partners, so-called implementing partners in Uganda, the Infectious Disease Institute, which has been doing in the past a lot of HIV-related work, but in the last few years has been doing a lot of TB-related work. And in the field of TB specifically, we're really seeing the dividends, at least in Uganda, from kind of a pivot that the U.S. Agency for International Development, USAID, made, 5 or so years ago, where it went from funding mostly organizations based in Washington that would hire local staff in Uganda, in my experience, to local organizations, locally run, many of the same staff, but just now employed by these local agencies. And I feel that they have done a great job in the TB program since they took over, like the last 5 years. You can see it clearly. I mean, I think case notifications are up 20 or 30% in Uganda. That's the term that is used when you diagnose someone and get them started on treatment. And, while there are initially a lot of questions, I think as we're all having, there's just been a complete lack of information. And I like how Dr. Tedros kind of highlighted the consequences of a very chaotic transition. But they have been very good, I think, at adapting and moving towards what they're looking at now, which is a chronic care model, where they're really now thinking about integrating their HIV clinics, their TB clinics. And while it's a little frightening for me as a TB doctor, who thinks that we have this specialized knowledge that can't be generalized to everyone else, they're moving forward with that. So I think kind of speaks to what, Jeremy, you were bringing up earlier, is we need to figure out how we can support them in that.
Yeah, Luke, maybe I'll just add to that. So I was on a call yesterday with colleagues with whom I've worked for years in Uganda on integrating HIV in hypertension into the HIV programs. And as you all know, integration of chronic care systems has underlined my work for over a decade. But we've still been dealing with parallel or vertical funding systems, right? So it was all about how do we leverage HIV successes and integrate into that. And then all of a sudden, yesterday on this meeting, we see a really well put together slide deck that came from ministry about just what you're saying, Luke, around chronic care clinics that include HIV and hypertension and mental health and all. And it was just really striking because it was clear that these were, and I know these were conversations that have been had over the years. It was in the process of being developed, but clearly what's happened in the last few months has catalyzed what we've been all talking about for years. And so, Christina, to your comment and question, there's a lot of tension there, right? There's a lot of excitement that this is the moment to do this, and then there's a lot of fear that, oh my goodness, what is going to happen to the information systems, the medicine supplies, all of this. So that was a personal reflection from just yesterday. I don't know if you guys have anything to add.
Yeah, I mean, Samoa, where I work, is a little bit of an interesting case. They have relatively less reliance on the U.S. In terms of donor funding than they do on other nations like Japan and Canada and China in particular, and relatively skeleton interaction with the WHO out there in the middle of the Pacific. So this they haven't felt as much, I think, of an immediate impact as other countries have, but it is in a similar way. It's accelerating conversations that are happening there about universal healthcare and the need to probably develop more sustainable financing models that allow them to fund their own health system. Interestingly, the thing in Samoa, and not to take us in a totally different direction, but interestingly, the thing in Samoa that has been the biggest concern among the Ministry of Health, so many of you may be aware, but there was a pretty significant measles outbreak that happened in Samoa in 2019, unfortunately resulted in the death of many children. There were very low vaccination rates, and so right now, Samoa's biggest concern is just the rhetoric that is coming from the U.S. in their opinion about the safety of vaccines, about fundamental kind of principles of health that we have all taken for granted for so long. And so they have kind of a very different set of concerns right now that are less linked to funding and more to just the message that the U.S. is putting out there.
Thank you. Good morning. I'm Laura Magaña. I'm the president of ASPPH, and we're going to be talking a little bit later, a little bit more about what you're saying. But thank you so much. I have been really enjoying this conversation. I have done extensive, almost all my life, global health work. And one of the things that I would like to just emphasize what you were saying, two things that really, I totally agree with you. One is that it shocked me how United States sometimes think that's not part of the globe. It's just like United States and the globe. Every time that we talk about global health here is more like the others. So I think that we have work to do there, because every time something happens here, like withdrawing from WHO or whatever, it's also affecting the United States. It's not like we're affecting the others, but it's just also United States. And we talk about climate change or whatever the topic is, I think it's extremely important to emphasize, and you were talking about that United States is also part of the planet. So it's just like one concept that I think is extremely important. And the other one that you also talk about it is that when we talk, for example, about the bilateral relations and how much United States benefit from having here international faculty, international students, it's not what we are doing to them. It's what we here in the States beneficiate from having them, that exposure. If we think about the competencies that, for example, our graduates, our students need to have in order to develop like empathy and the cultural, how do we think we can develop those if we have never been in another country? And maybe we have never gonna do that, but we can have here that experience if we know people from other countries, people that don't think like us, that don't look like us, that, have different cultures. So I think we need to emphasize in academic public health the importance of having here the presence of others in order to be better ourselves. So I just want, you say it very well, but I just want to emphasize those things that I think are extremely important, and there's work to do in those areas. So thank you.
Thank you so much. Tracy, I feel like you can, so maybe two elements here around the importance of bidirectionality and having our colleagues here with us, and then maybe some comments about the importance of local global health, that construct, and thinking locally.
Thank you for those comments. As you were talking, one thing I was thinking about, so part of the relationship that I co-direct with a colleague, Harriet Mayanja in Uganda, is focused on bidirectional clinical education. So we bring medical students, we bring faculty from Uganda here, and we also send our trainees and faculty to Uganda. But I think consistently, one of the things that I think is so meaningful about the experience that the Ugandan students have, and even the Ugandan faculty will share this too, is this recognition when they're working with their colleagues here that actually their education is fantastic. And in many cases, they are better prepared to do things than some of our folks here. This sense of, they almost felt like, well, we were trained at a school, but it's not Yale, and so everybody at Yale must be this way. But really coming away from their experiences here, feeling really confident about their training and really confident about their colleagues that they're working with at home. And I think that's actually, it's not something that is easy to capture on your sort of list of, what's the return on investment of bringing people. But I think that sense of confidence that then people take back home with them, and they go on to teach others, and they go on to collaborate with others, continue their collaborations here. I think that is something that's really important, but not as tangible as X number of papers published. So I think that that's just something else that I want to just highlight. In terms of the local piece, I think that's something that our Office of Global Health, I see Sheila Shenoy, our Associate Director, is here, as well as Laura Crawford, our lead administrator in our office, is here. We've really focused over the last 7-8 years on developing our sort of local global health profile as well. We have clinical educational exchanges with colleagues in rural Tennessee, thinking about working with the Indian Health Service, thinking about working with a lot of partners here in New Haven, and really taking opportunities to make sure that our trainees are getting outside of the clinics and outside of the hospitals and working with partners in the community. And thinking about, well, what is the perspective we're gaining on patients and on research questions when you're not just sitting in the clinic and seeing people coming to you and hearing about the struggles of our community colleagues as well as patients and living their lives. So, yeah.
Other questions or comments?
Thank you so much for this. I'm actually going to throw the question I was going to give to Dr. Tedros at you guys. So, good, best of luck. So, one thing I've been very concerned about, especially in regards to what you were saying about the idea of the fact that obviously we're part of the globe and we're part of global health, is that we aren't sharing data and we aren't giving notifications on, potential outbreaks or public health emergencies to the WHO, which of course is negatively impacting the work they do in the emergencies program to really, maintain that surveillance. I've heard from some of my former colleagues at the WHO that they are getting some more informal notifications, kind of under the table a bit, but they are no longer getting that kind of regular systematic update from the US federal government. So my question to you is, how can we as an institution here support that? So in the absence of a more, again, formal notification system, how can we fill that gap? Thank you.
It's a difficult question, and a lot of the issues are probably legal and other types of issues that I'm not expert in, and policy issues. But I would just say that if you think about the way that we do surveillance in this country, and there's others in this school who are more expert than I, we have a lot to learn from the way it's done outside the U.S. And maybe that's a good place to start. Is if if we're going to be sharing data, as we figure out ways to share data, how can we actually do a better job? Right now, I think everybody's very familiar. We have pandemic influenza strains that are circulating in livestock in the US, and we're really not doing a great job of looking at that. And if we think back to the pandemic, a lot of the sentinel events that helped us be aware of new variants emerging were from global partners like South Africa that had really fantastic systems. So I think that might be a start, is to think about going to be difficult in this time when there isn't a lot of funding for public health, but as universities, we have a great opportunity, and I believe there are some initiatives here, even within Yale, to kind of contribute to sharing genomic information that could help advance that.
I'd also open up the answers to, or the opportunity to answer to the audience. And I don't know if others in the room have particular expertise.
While we're waiting, I'll just say, I don't necessarily know what would be the best formal structure for that, but I can say that this just goes back to the importance of the relationships that we all have with our colleagues in different places, different organizations, but different countries. And I think, in, again, partnering with colleagues in Uganda, where there are frequently hemorrhagic fever virus outbreaks, and sometimes it can be tricky to get information that's verifiable about sort of the extent of those outbreaks. I rely very heavily on my relationships with colleagues and partners to be able to help me understand what we're seeing on the internet and what we're seeing in the international news, and really get a sense of, well, what is the real issue? Where is this happening? And so although you'd hate to have to move towards depending on informal networks like this, I do think that that's an important piece of the ecosystem to be including.
Good question.
Thank you so much. This has been absolutely fascinating. One common theme I've heard from all of you is the importance of long-term relationships and collaborations, which can't be easy. I was wondering if you could share with the room how you've done it. Nikki in Samoa, others in Uganda. Surely there have been ups and downs. Have you overcome conflict? What are the secrets? How do you do it?
All right.
Yeah, that's an amazing question. I think it's one that I get asked fairly often on the end of a 15-year relationship. You show up and you do more listening than you do talking. You find ways to have humility and acknowledge the privilege that we have coming from Yale. There's a huge, people see Yale and they have a set of expectations about who you are. And so being very careful to establish my individual humanity outside of what my institution represents. We have had many, many missteps. We've had to repair many things. I often think about what best prepared me to have the relationships I have in Samoa. And interestingly, I recognize we have the president of ASPPH here, it's probably not my academic training. It is the years, interestingly, that I spent waitressing. So I paid my way through my PhD program in the UK. I was a waitress 5 nights a week and all day on Sunday. And what I learned in that moment is to make sure everybody feels like they're being heard, to understand how to deal with conflicting priorities, to think about the whole system. And those soft, human skills are the key to these partnerships. So as much as what we learn here at Yale in terms of rigor and analytic capabilities and everything, we also, those soft skills are what have made it possible to have a decade-long collaboration. Every time I go to Samoa, I have a fear the night before I fly that I'm going to get there and my passport's going to be when we get to the door, some reason I've done something terrible to get myself thrown out. But in 15 years, I haven't done it so far. I hope not to. But those human skills and ability to apologize when we're wrong are really important.
Yeah, I was literally just going to say the same thing about being a server. So, but just to sort of put maybe an academic point on it, I guess. So I was part of a multi-year project that was funded actually by USAID called the STAR Project, where we basically looked at what are the different qualities that make for successful partnerships between academic institutions in LMIC and HIC, and then also different other academic institutions and other partners. And for folks who have been part of the Global Health Seminar, they will hear me talk about this. After a number of years after reviewing hundreds of papers, multiple investigators or multiple faculty working on this from different countries, when you look at the list of things that came out as the most important aspects of having successful partnership, these are all those sorts of skills that you learn in kindergarten. I mean, it's really just how do you treat people, treating people with respect, listening to people. I'm happy to share the link to the report that we wrote. But when you really boil down this list of ingredients, these are things that we all know. And as I often will say to students, given that we all know these, usually the students will even come up with the list at the beginning of the class, and then I'll sort of go through it. It's the systems around us that make it challenging to actually implement what we know to be true about how to have healthy relationships with other people. And so that's really where we need to be focusing, is on what are the systemic barriers to healthy partnerships. And so I think that's something that I've really tried to focus on in some of my work as well.
Yeah, maybe just a brief thing to add is that I think an important part of resilience in these partnerships is really going beyond the disease that you work on. The way that I was able to get my career started was because people in other fields really took the time to show me how to do things that I could then apply to tuberculosis. And one of the nicest things for me, I think, since coming to Yale, is that I've been involved in a partnership in Colombia. That's a really long-standing partnership. It's really led by Professor Nancy Saravia, who lives full-time in Colombia as one of our secondary faculty. And in the Department of Neurology and Microbial Diseases, we're really fortunate to have a huge number of faculty who are full faculty. They teach our students, they mentor our students, they're based there. And Nancy came here about 10 years ago when her longtime collaborator, Diane McMahon-Bratt, was retiring, really to kind of renew the partnership. She does that all the time. She brings people in, and that's kind of led us to have a TB partnership, and there's now a new partnership related to dengue. And so over time, these things can be sustained by those types of partnerships as well that allow you to keep the partnership alive and going.
Yeah, maybe I'll add a few comments to those. I echo the comments about bringing your humility and your humanity to the table all the time, and also offering opportunities to your collaborators, colleagues that they might not have otherwise had, that just inherently make sense. So an example, we had a contract with WHO a few years ago to review the essential medicines list and look into cold chain requirements for medicines on the essential medicines list. And it was a contract between our NCD group here at Yale and WHO, and we could have proceeded and gotten Yale students involved, which we did. But we also engaged our partners in Uganda because I work with folks in the pharmacy department and Ministry of Health and other institutions there that know much more about these pieces of the puzzle than we would here. And what resulted, though there were many challenges that created in terms of funding and just the sheer mechanics of collaborating, it really enriched the process at the end of the day. And it not only made for a better product, but it offered opportunities for them to engage in a way that they wouldn't have otherwise had. And so I think being cognizant of that, especially at a place like this where we have so much opportunity, being aware of what those opportunities, what might be lacking for our partners elsewhere, and how to try to lift up maybe all boats simultaneously. Oh.
Thank you so much for sharing your reflections and experiences. I was very excited to ask Dr. Tedros a question, which is specifically about the pandemic agreement, and that was actually why he couldn't be here today, right? So this is a pivotal week, 13th time that member states are discussing this agreement after 3 years. So I was just wondering if you have any comments about it. It's actually the topic of my MPH thesis, so I'm very passionate about it. And yeah, I was just hoping to hear from you as well. Thank you.
Can we hear more from you? What? Can you tell us a little bit more about it? Because you're the expert in the room.
Well, I'm specifically researching the role of climate change within the agreement, which is not the most important thing in the sense that there are like other Like the main provisions would be, for example, this PAP system of pathogen access and benefit sharing to ensure that genetic materials are shared from, for example, developing countries, but then the benefits of vaccines and the diagnostics and everything that's made from the virus or the bacteria gets back to those countries. So there's like many important provisions, and I really hope it comes to consensus. And as I was saying, like my role, since I'm very passionate about this intersection of climate and health, is to look how member states are considering climate considerations within the agreement, as we know that climate change impacts zoonotic spillover, so for prevention, but also in terms of preparedness and response, climate change hinders the how health systems can withstand extreme weather events. So basically, my research is more like on this climate change aspect. But there's so many other aspects I would love to learn about regarding the agreement.
You did a great job explaining or answering your own question. But maybe to open it to the room, unless any of you have comments. I will admit I'm not keyed into as much as I should be about the accord.
I will say, I also am by no means an expert. I think, having followed this sort of peripherally, I am really excited. It sort of goes with my enthusiasm about just the existence of WHO. I mean, I am excited that countries are trying to learn from the mistakes that happened during COVID. I think, there's been so much work academically in thinking about how are we better partners with other universities, and how can we be better partners and think about equity. And this was a big situation where we did not do a good job. We did not take from those learnings. We sort of reverted to these sort of very tried and true patterns of human behavior that are not necessarily the best way that we want to be presenting ourselves to the world. And so personally, I just, when I learned that was why we were needed to come and be on this panel, I was thrilled, because it means that hopefully we're getting somewhere.
It'll be very exciting.
Sunil, did you have a question or comment? I think we're almost out of time, so maybe the last. Yeah, you were the last.
Thanks, Jeremy. I think one of the biggest challenges to global health and making, I'm going to say the bad word, equity, is the language barrier with, really English dominating literature, published literature, scientific meetings, so much of Latin America, Francophone countries, and not to mention all the dozens and dozens of Asian languages not represented. Any thoughts on how we can work as an academic institution to try to break some of those barriers down?
I think we need to be teaching languages more to our public health students. I don't know how we fit that into the curriculum, but we probably should be thinking about how that should be emphasized more. I'm just inspired by a family member who is involved doing international work, and that was a very critical part of his training. He had to spend a year, doing intensive studying the language in the countries that he was going to be working. And nobody questioned that was a very important part of what he was supposed to be doing. But we really have not made that commitment, in spite of all the many years that we put into training to do global health. We don't include that. So maybe that's something we need to think more about.
So about 18 months ago, my research group made a conscious decision that we were going to submit a Samoan language abstract next to the English abstract in every paper that we've submitted. As yet, not one journal has agreed to publish it side by side, which is a real disappointment, but we always end up with putting it in the supplementary materials that's available online. So we can continue to do things like that attempt to disrupt a system. And I will let you all know when I find the journal who finally lets me do that, because I think there are systemic issues we also need to fix.
That's inspiring. I think we're out of time. So, as Mike gives me the... this was last minute, but really fun. Thank you. Thank you all for allowing us to do this and participating with us. Look forward to the rest of the day together. Thanks a lot.